patients had 2 or 3 or 4 C-sections, and you know there's going to be some scarring in the lower uterine segment. But there's always that safe space between the scar from the cesarean and your uterine arteries, right? Because most of us, if we're doing C-sections, and I haven't done one in a while, but I'm pretty sure they still try to avoid the uterine arteries. And so when they're closing your hysterotomy, from the C-section and scarring, there's always that little window, that little safe window just anteriorly. So even if your uterus is plastered to the anterior abdominal wall, dissect posteriorly, jump over the uterines, and just bluntly just push whatever's there and just isolate your uterines. I watched a video as part of the training and could see it vaginally, where they placed the ring, not because they hadn't made their colpotomy yet, placed it up against that C-section scar and blew it up. And you could see that black, dark, because it was insufflated from the posterior colpotomy. So that black, thin, single layer of peritoneum, you could see your uterines that you'd already gotten or were going to get on the lateral aspect. But just anterior to that, I could see the backside of that. And it was a very light bulb moment for me. I was like, there it is. That's the spot. We found, again, I found it on the other side. It took me seeing it to realize what it was. And all of a sudden you go, okay, officially I get it now. I can sort of imagine how once you find those opportunities, because there's like any surgery, where are your safe spaces? Where are your opportunities for success? I saw that and go, okay, now that makes so much more sense. There's a completely safe space. I can just see it clear as day. And so again, that was a moment for me where I thought vNOTES was pretty cool.
Yeah. You describe it beautifully. I can't describe it any nicer than you did, but that was exactly what I felt the very first time I tried it. Because I thought, how can I try and reduce this rate? Can I place the ring in? Tried all sorts of setups. And then when the first time we put the ring that way and saw that, it was like, but now we can do these difficult colpotomies where in a normal vaginal hysterectomy, you're stuck. You can make your posterior colpotomy, tie off the uterosacrals, but if you can't make an anterior colpotomy, you have to convert to laparoscopy. But now, yeah.
And in a vaginal hysterectomy, you're pulling the uterus down, you're compressing that tissue, you are making it more difficult. And what they keep stressing was push that uterus away, push the uterus away, push the uterus away. Just like you're doing from below with the colpotomy cup laparoscopically, you're doing it yourself. And by pushing it away, you're exposing those windows to allow you to visualize those small spaces much more largely.
Exactly. And you have a double flow of carbon dioxide. You have your flow that goes behind the uterus and opens the space in the abdomen. And because you have that empty space there, as you describe it, it's blue or black, the peritoneum, because there's nothing behind. And where your bladder is, it's actually white. It's not. There is something behind it. So that really, really helps. And if it's one of those uteri that's plastered to the abdominal wall, you can basically do your whole hysterectomy and just leave the uterus hanging on the C-section scar. And at the end, you shave the scar like you shave endometriosis.
And that's the same way we do it laparoscopically. I mean, I think many of us, when we first get in there, when you're doing an abdominal hysterectomy in training, that's where you start, because that's where your abdominal incision is right on top of the mess, is right in the scar. And when you get in laparoscopically, and you learn that's the last thing we do. If you see someone start chipping away at the scar first, it's like, whoa, stop. Let's get all the blood supply, and then we have a little dead uterus we can chip away. Seeing that done from below with the camera was pretty exciting. I thought that was pretty neat. I think the other thing I was trying to visualize that will take some time is the ureters, because as we have that ring in, the bladder's anterior to us. The ureters are coming in lateral. The ring, like you said, it pushes it out of the way completely, right? They're just, once you've gotten your uterines first, I imagine the ureters are just now nowhere near. Not that you ever ignore them, but they're nowhere near where we're operating once the uterines are taken.
I think the moment when you're closest to your ureter is when you're coagulating uterine artery. And that's actually the only moment when you're close to it if there's no endometriosis and they're in the normal position. The whole bend of the ureter into the bladder is behind the plastic sheet. And I think laparoscopically, where we have our ureteric injuries is not where we go and dissect it to find it. It's usually when we coagulate too close to the vaginal cuff. It's right where the ureter goes into the bladder, the point where you normally don't even dissect it laparoscopically. And that area is protected by the Alexa sheet. And then the ureter at the level of the uterine artery is lateralized a bit because of the pressure of the ring.